Hi, I'm Dr. Walker, and we're here for part 2 to continue our discussion on the shortness of breath. And we started last time with our patient who is a 52-year-old female. She had low oxygen saturation on arrival, it was 78%. We placed her on oxygen by face mask, and now we have her sitting up. We asked her a sample history, like we do with all patients that come to the emergency department, in order to get some basic facts about them. She is allergic to dust. She's been having trouble breathing. She's not taking any medications, but her past medical history says that she does have some past problems with breathing. We check out more of her history and find out that this started about 2 days ago. She was exposed to dust a few days ago, did some sweeping at her house. She's finding it difficult to catch her breath. And this is worse than her normal problems that she has breathing. It's been gradually worsening, and she feels short of breath, she's coughing, and she feels a little bit lightheaded. So initially what we need to do is undress the patient so that we can certainly tell what the physical exam looks like and helps us with our even general impression. And part of the reason for doing this is to make sure that we can assess for accessory muscle use in her work of breathing. We check her body position and see if she's needing to be in a certain position to breathe, or we can help her get into that position that's most comfortable for her. Anxiety is certainly a cause for concern, as that can be a sign of hypoxia. Somnolence can mean that a patient is hypercarbic, but it also can mean that they're simply tiring out from breathing. So those are two concerning symptoms. So here we remember that we have her sitting up, and she is having a family member. We'll have a family member help her do this. Also, you can put the head of the bed up if the hospital that's available in your hospital. We see here that she looks really tired, and again, kind of somnolent, so we're not sure if that's her tiring out or maybe just getting too much carbon dioxide. We can zoom in here and actually check out her neck, where we see that she has some accessory muscle use in the suprasternal area. These are examples of accessory muscles. And then I just want to show you another example of a different patient this is intercostal accessory muscles. And I'll just point out where I'd like you to focus is kind of in this area. You see that the patient's using his rib muscles to help him breathe. So we're going to go on that with anatomy. We've all studied anatomy, and some of us are studying it now, to use anatomy to think about the differential diagnosis in this patient. So we have a picture of the chest and lungs, and what we want to think about is kind of starting from the airway. A lot of things in the airway can cause problems with breathing and can cause shortness of breath. So if you have a foreign body in one of the bronchial trees or the trachea, a mass, infection, swelling that can cause anaphylaxis or swelling for other causes. So on physical exam, what we want to check for to look for problems in the airway is signs of stridor, drooling, choking, if a patient is unable to swallow their own saliva. These are signs that there's a problem in the airway. So after the airway, let's do a lung exam. And the reason that we're obviously going to focus on the lungs is because a lot of causes are in the lung for shortness of breath. We have pneumonia, asthma, COPD, pleural effusions, pulmonary edema. So we want to do a very detailed exam of the lung. There's also, when we focus on this anatomy of the lung, we also have to really discuss the pleural space. So the pleural space is the space in between the lung and the chest wall. And it's actually usually a potential space with nothing in between the two. But sometimes, as we'll see in this video, that space can be damaged, as in a stab wound or a rib fracture, which causes things like a hemothorax, which can be blood in the chest wall, a pneumothorax, which is what we see here. And we'll just watch the video for a second. This is a tension pneumothorax where air is in between the chest wall and the lung and causing the lung to collapse. So in order to figure out some of these lung causes for shortness of breath, we have to do a pretty detailed physical exam. So here, our provider is listening to the lung fields of our patient, and he's listening anteriorly. He's listening for wheezes, rales, bronchi, and it's important to also listen posteriorly and laterally, so listening to all lung fields, which we show here. And let's just take a listen and hear what our patient sounds like when she's breathing. So that sound is wheezing, and it sounds like she has bilateral wheezing that sounds pretty severe. So let's move on to the heart and the cardiac exam. So the reason that we need to do a good cardiac exam and circulatory exam is because there's a lot of cardiac causes for shortness of breath. You can have a myocardial infarction, coronary artery disease, congestive heart failure, arrhythmias, structural heart disease. So in addition to listening to the heart for murmurs, we want to check our patient's circulation status. So not just the pulse, but her volume status, which we're doing here. The provider is checking for peripheral edema. We also want to check for JVD in the neck. So speaking of circulation, there are a lot of arteries and veins inside the lungs. So this is a video of pulmonary vessels. Certainly you can see that there's a lot of them, so there can be a lot of problems. Specifically, one that is an emergency and can cause sudden death and shortness of breath is a pulmonary embolus. So that's something to keep in your mind for a differential diagnosis. Also, pulmonary hypertension can cause problems with the vasculature inside the lungs. We have musculoskeletal causes for sure that might cause shortness of breath, and this is something that we will examine more closely on our chest wall exam. So we're looking for rib fractures. If someone had trauma to the chest, they can also have just a bad muscle strain that can cause them to have trouble breathing because it hurts so much. So on our chest exam, we want to evaluate for crepitus, any signs of trauma or fractures. We can also percuss the chest, so any hyperresonance would be a sign of a pneumothorax because of the air located behind the chest wall. Dullness to percussion means that there's liquid or a pleural effusion behind the pleural space or mass, some dense structure. So for our patient, she does not have any of these problems. She doesn't have any crepitus and she doesn't have any dullness to percussion. So in our patient, we remember that she had retractions, so she had an increased work of breathing. She did not have any JVD. She did have bilateral wheezing. On her cardiac exam, she had no murmurs. She was tachycardic, but she did not have any peripheral edema on her extremity exam. Her chest wall was normal, and her skin was a little diaphoretic. So we moved back to the emergency medicine approach, and we remember that we assessed her initially and treated her immediately with a few key interventions. And now we're reevaluating her and getting a little bit deeper into what the differential diagnosis we think that she might have. So when we reevaluate her, we really need to think through some of these causes that are pretty common and dangerous causes for shortness of breath. So does she have pneumonia or pleural effusion? Is it a pneumothorax or asthma? Does she have a cardiac cause for her shortness of breath? So we'll talk a little bit more about that in part 3 of the shortness of breath series. This is the shortness of breath differential is very long. So we also want to remember that there can be metabolic causes for shortness of breath, electrolyte abnormalities that can cause arrhythmias, renal failure. The list can be pretty long. So one of the things that we'll need to do is take a very detailed history and possibly do some diagnostic testing to figure out what happens next. So in summary, the differential diagnosis for shortness of breath is extremely extensive and long, and the way to get through it is to do a very detailed history and physical exam, which we've done in this patient. There are probably still some questions that we need to ask to narrow it down a little more, but 2/3 of patients with an emergent cause for shortness of breath have a cardiac or lung etiology. Thank you, and this completes part 2 of shortness of breath.